শুভ সন্ধ্যা। সবাইকে স্বাগতম বরাবরের মতো। আর সবাইকে বলে নিচ্ছি, আসলে আমরা গত 2 সপ্তাহ আমি এবং আমাদের চিফ এডিটর ডক্টর শামীম দুজনেই আসলে ব্যস্ত ছিলাম, যে কারণে রেগুলার ওয়েবিনার গুলো আয়োজন করতে পারছিলাম না। তারপরও কিছুটা আসলে কিছু দুঃখের বিষয় ছিল, কারণ আমাদের চিফ এডিটর ডক্টর শামীমের বোন 2 দিন আগে আসলে পরলোক গমন করেছেন। আমরা তার বিদেহী আত্মার মাগফিরাত কামনা করছি। তো সবকিছু মিলিয়ে আসলে আমাদের একটু দেরি হয়ে গেল, তবে খুশির ব্যাপার এই যে আমরা আসলে পরপরই চেষ্টা করব সামনের দিকে অনুষ্ঠানগুলো করার। আজকেও তার ব্যতিক্রম নয়, এবং আজকে আমাদের সাথে একজন বিশেষ স্পেশালিস্ট এসেছেন, যিনি ইন্ডিয়াতে এবং একটা প্রতিষ্ঠানের হেড অফ দ্য ডিপার্টমেন্ট হিসেবে ফিজিওথেরাপি কর্মরত আছেন, ডক্টর শগুন স্যার। তো আজকে আসলে আমরা তাকে ওয়েলকাম জানাবো, এবং পরবর্তীতে আসলে উনি স্পোর্টস নিয়ে আসলে পারদর্শী, বিশেষ প্রশিক্ষণপ্রাপ্ত। তো তার কাছ থেকে আসলে আমরা স্পোর্টস এর সফট টিস্যু, বিশেষ করে জানি যে আমরা খেলাধুলাতে সাধারণত মাংসপেশি বা হাড় সংক্রান্ত কিছু থাকে, কিন্তু বেশিরভাগ ক্ষেত্রে মাংসপেশি বা লিগামেন্ট এই জাতীয় সমস্যা আমরা ভুগি। তো এগুলোকে আমরা বরাবরই সফট টিস্যু বলে থাকি, এবং এর চিকিৎসায় কিছু টেকনিক আমরা বা কিছু জ্ঞান 1 ঘন্টার মধ্যে তার কাছ থেকে শেখার চেষ্টা করব। তো আসলে আমাদের সাথে অনেক দেশের পার্টিসিপেন্ট জড়িত, সুতরাং তাদের জন্য আসলে ইংরেজিতে চলে যাচ্ছে। So first of all, I would like to welcome you all our participants, especially not from this subcontinent, like that happens regularly from Bangladesh, India, and Pakistan, Sri Lanka, Nepal, and we have a lot of participants from abroad and another country like African countries, Middle East, and sometimes we have got from USA and Canada also. So I would like to everybody to please have a attention, because this time I think we have already we have passed 2 weeks without webinar regularly. Sorry for that, because of some personal and private issue, because our chief editor Dr. Shamim, his sister has gone due to cancer, and that's why he was little busy with that work. And sorry for that, and we are condolence for her soul, departed soul, that God may took her in heaven, and that's why we are not used to arrange our webinar. But special thanks to Dr. Harpreet Singh sir. He's our mentors, and we all Bangladeshi people have learned a lot of things on proprioceptive neuromuscular facilitation approach from him. So he has given us a nice opportunity to invite Dr. Shagun Agrawal sir on our platform for today, and we have kind enough to manage his valuable time for us. And next on our, he will be going to present something very special, because he has completed his BPT and MPT on his sports health, and also he has completed his Doctor of Physical Therapy from Spain, and now he is the professor and head of the department in physiotherapy in Institute of Applied Medicine and Research, Ghaziabad, that is mainly in Delhi and India. So we have a nice scope for today. That is, we can make a good bridge with sir, and we can learn something especially from him. And because in case of sports injury, it's a very common thing that we at the physio have only scope to heal that soft tissue. So we have the chance, best chance, and I think sports is the unique part for physios. So we can learn something, and this is the starting our breathing. So in near future we can get more and more. So I will not kill a lot of time. I think it's time for you, sir. So, sir, thank you, and it's over to you. Thank you, sir.
Thank you. Thank you. I would like to welcome all the audience on the Physio News channel. Shobho Vikal from my side, because our roots are same, because the Indian continent is there. We all Indians, Bangladeshi, Nepal, and all the Sri Lankans, we are from having the same roots are there. So I am having the same roots just like the Bangladesh. So thank you for giving me this opportunity for this platform. Myself, as Dr. Shantanu has told you about myself, I am just your physio colleague. Today, I am going to take lecture on the soft tissue mobilization is there. This topic is quite close to my heart is there because what I find it out, God has given us a lot of flexibility. We are born with a enormous flexibility is there. You could find it out a child can hold bottle with his or her legs, but as the gradually our age increases, we are losing our flexibility. And you can see in the my next slide, now we are like this is there. We are spending our lot of time in front of the laptop or the any gadgets, and we are saying a lot of problems are there in our cervical spine, lumbar spine, blah blah blah. And whenever you ask to any physio or any osteopath or any orthopedic surgeon, he used to say, okay, there is a misalignment is there is a spondylitis is there is a lot of problem, osteophytes are coming and like this. And then they go for your manipulation or the mobilization techniques, and at that time we use high velocity thrust, we use the osteopathic techniques, we use different mulligan and all different techniques we use. But what about the scenario about the muscles? So after a 22 years of the experience, what I could say, the most painful disorders are not the local afflictions, but this involve the entire locomotor system is there. That's why we practitioner must consider the muscle and motor control issues in addition to the your joints, ligament, and the disc. Never just go for the conclusion that there is a problem in the disc is there is a facet joint problem is there is a protrusion is there. Just don't go onto the conclusion of the disc problems or the joint problems. This could be the problem, could be from the muscles, and the motor control issues could be there. That's why I focus our treatment should thus address all the myofascial dysfunctions, whether painful or not, to prevent the development or reoccurrence of a musculoskeletal pain syndrome is there. In the board, I have written whether painful or not. Sometimes they won't be painful, but you have to focus onto the myofascial dysfunction. I would like to tell you how the dysfunction starts in the muscles. Whenever there is anything, any trauma to your muscle is there. If I pinch my triceps, okay, what would be there? I would go for the hypertonicity. So first symptoms that comes in our muscle is there, that is the hypertonicity is there, and it can result from pain, overuse, repetitive motion, stress, injury, fatigue due to poor posture or deconditioning of the neuromotor system is there. So anything is happening, your muscle is going in the hypertonicity. This hypertonicity would restrict our range of motion, and it would be inhibited because of the Sherrington's law of reciprocal inhibition. And this thing goes for irritability threshold is tend to be hyperactive during this movement. So at this juncture, either you can control your overuse, you can go for the treatment for the muscles, but we never go. And ultimately, then the muscles go for the muscle go for the tightness. If you are pinching your muscles again and again, then they say, okay, they are hurting me. And the muscles further will go in the tightness. And muscle tightness is a form of the hypertonicity is there, in which there is a lowered excitability threshold is there, and the all tight muscles would become short at the rest time. Still you are not taking care of the muscle, then this tightness can be converted into your myofascial trigger points. Now that there would be development of the trigger points would be there in the muscles. What is the trigger points are there? These are trigger points are the another form of the hypertonicity, which was explained by the Simmons and Travel in the Punjabi, a hyper irritable spot found within a taut band of skeletal muscle or its fascia, which when provocatively compressed will give rise to characteristic referred pain, tenderness, and the autonomic phenomena. You can find it out in the right hand side of diagram. There are a lot of the red spots are there. These are the myofascial trigger points that are present in the muscles. Firstly, there was the hypertonicity was there, then there was tightness, and ultimately there is the development of the myofascial trigger points are there. These trigger points can develop up in hypertonic muscles due to the spasm, due to the pain. They can develop in the hypertonic muscles because of inhibition or the deconditioning. And this can develop muscles after the gross trauma, just like the whiplash injury, muscles that has been overworked. It could be due to the response to the limbic system of hyperactivity, responding to variety of other indirect stimuli is there. So, dear colleagues, we are finding it out. Our muscles, first it was going in your hypertonicity, then there was the tightness of the muscles was there, and then there was the development of the myofascial trigger points are there. Then the another thing I would like to tell you about the movements pattern is there. Faulty movement patterns are there in our body. Our brain thinks movement globally. My brain doesn't know this is the flexion, this is the extension. These movements are given by the physiotherapist. But our brain knows the global movement. My brain knows how to eat, how to comb hairs, how to go for the right, how to go for your gait. Okay, so what happens up? My brain thinks globally and brain wants to complete his work. If any muscle is not working, it would go by the faulty movement pattern. And the faulty movement pattern are believed to be a contributing factor for injury development, and the reoccurrence is there. So that's why when you are evaluating movement pattern, it is necessary to observe the overall stability of the system when the movement is performed instead of actual activation sequences. So when you are assessing your patient, don't think, okay, this movement is okay. See the pattern. Is the prime movers are working? Is the stabilizers are working properly? Agonist and antagonist are working properly or not? So the important factor is whether the spine or the extremity joint is stabilized approximately when the movement occurs, or whether there is excessive movement as a result of inefficient muscular stabilization is there. Along with this stabilization, we have to pay attention to the degree or quality of the contraction during the particular movement is there. And my colleagues, what I find it out with the genders concept, gender says there are the 7 faulty movements patterns are present in our body is there. To complete our work, there are the faulty movements are there which developed in our body. And these faulty movement patterns are hip extension, trunk flexion, hip abduction, neck flexion, shoulder abduction, scapular stabilization, and the respiration. I would like to show you one by one what could be your faulty movement pattern could be there. Just see in this slide, I said my client to go for your hip extension. Hip extension is the primary work of the gluteus maximus is there. But see in the diagram of the B and the C, you can see in the diagram B, there is a excessive anterior pelvic tilt is there during your extension. And in the diagram C, you can see there is a knee flexion during the hip extension is there. So what is happening? What is happening? This is the faulty movement pattern is there. To complete its hip extension, it is using up the accessory muscles. So you can find it out this faulty movement pattern. Second, again you can see in this hip extension, you can see there is a excessive lumbar lordosis is there. There is a pelvic tilting is there. See, in your shoulder abduction, when we go for the shoulder abduction, we should see the scapulohumeral rhythm. When this patient is sitting in a beginning position, you can see the winging of the scapula. Okay, so when we go see the abduction, because of the poor scapular stabilizer, there is the reverse scapulohumeral rhythm is there. And these faulty movement pattern would lead to your fault in your body. Just see in the next diagram, you can find it out, the winging of the scapula, and you can see the tilt in your cervical spine is there. Then I go for to your chin flexes and the chin lifts. So always I find it out, there is your deep neck flexors are weak. And because of this, we use our sternocleidomastoid and we use the accessory muscles for the chin flexes. Then again, the next movement is the trunk flexion. Our core is weak. Because our abdominals are weak, we use the excessive hip flexion, we uses the knee flexion, and we uses the plantar flexion is there. And you can see in my slide, my physio person is giving stabilization on your ankle. Still, there is a excessive movement is occurring on the hip flexion is there. And then see the next movement is your respiration. Usually our respiration should be either thoraco-abdominal or abdominothoracic. But nowadays you are finding it out, our tidal volumes are decreasing and we are using accessory muscles for the respiration. So first you find it out, there are the myofascial trigger points are there. Then the things you find it out, there are the faulty movement patterns are there. What this causes? These causes the postural syndromes in our body. What is this postural syndromes are there? These postural syndromes is a result of the muscle imbalances that develop in our musculoskeletal system. Postural distortion occur that tend to correspond with the muscular finding. And there are three typical postural syndromes are there. Lower cross syndrome, upper cross syndrome, and the Lear syndrome. Just check one by one. If we see in the upper part, the upper cross syndrome is there. It affects our neck, shoulder girdle region. How it is characterized? It is characterized by the forward head carriage, in which there would be the upper cervical extension would be there, and on the lower side, lower cervical flexion would be there. There would be the rounded shoulder, elevation and protection of this shoulder, and winging of the scapula. This all has happened because of your faulty movement patterns. What happens in this thing? There is a cross syndrome is there. What happens up in one cross, there one muscle group of the muscles, they get inhibited and they become weak. In this upper cross syndrome, what happens up in our deep neck flexors, they become weak. And the cross of this part, our scapular stabilizers of rhomboids and serratus, they get weak. And making another cross, there would be your tight trapezius and levator scapulae, and the tight pectoralis major would be there. You can see again in this diagram, in the cross syndrome, so your deep cervical flexors are getting weak and your rhomboides and the mid and lower trapezius are weak, and contrary to other side, there is your shortened upper trapezius and the sternocleidomastoid is there, and the pectoralis major is tight. What happens this? Functionally, upper cross syndrome alters the dynamic stability of the cervical spine as well as all the activities involving prehension, because we use our upper limb mainly. So what happens when there is upper cross syndrome is there, your COG, center of gravity line, changes, and now the more pressure comes onto the C5, C6 and C6, C7 cervical vertebra. Because of more pressure, more weight bearing on the C5, C6 and C6, C7, you would find it out there is the hypomobility on the C5, C6, C6, C7, and there would be pain would be coming on this reason. But is it because of the hypomobility? And now my few clicks would say, okay, we would be going for the high velocity thrust or the cracks for this hypomobility. But I find it out the reason is your upper cross syndrome is there. So we have to think about the treatment of the upper cross syndrome. So you can see as your forward head posture would be increasing, the pressure onto your lower cervical spine would be increasing day by day is there. It should be the correct posture like this, but due to your postural syndrome, your posture would be changing. Similarly, in the lower part, there would be the lower cross syndrome would be there. It affects lower cross syndrome. It affects the lumbopelvic region. This would be characterized by there would be anterior pelvic tilt would be there, and that would cause the increased lumbar lordosis and the pendulous abdomen. We Asian are having the high BMI highest because we all are from the Bengal origin. We love the sweets and all this. So you would find it out. We are having a good tummy, and because of this, what happens in the lower cross syndrome, again a cross is becoming, and you would find few muscles are getting weak in a cross. Which muscles are these? These are the weak abdominals and the weak gluteal maximus is there. And reverse, contrary to this part, there would be the tight erector spinae and the tight iliopsoas would be there. Now, because of this anterior pelvic tilt, increased lumbar lordosis and pendulous of the abdomen, now your COG would change. Now the main weight bearing would be coming on the lumbar spine of the L4, L5 and L5, S1. And you would find there is a pain in this area is there. There is a hypermobility is there. And we would say, okay, we should go for the manipulation of the spine would be there. But again, I am saying the cause is your lower cross syndrome is there. We Asians, we love the sandwiches. We love there should be the layering of the butter, and again, there should be more of the good stuffing in the sandwiches is there. That's why when we are not satisfied with the upper cross syndrome, lower cross syndrome, we just go for the combining of the upper cross syndrome and the lower cross syndrome, and that result in the layer syndrome. And this is the chronic postural distortion resulting from a combination of the upper cross syndrome and the lower cross syndrome. And it appeared to be alternating layers of the hypertrophic and the hypotrophic muscles are there. So alternating layers, we would be finding it out. So now you would see there is a viscous cycle is there. It has started, take it from anywhere. A small pain has come. It leads to the tightness in the muscles. It was forming the trigger points, and trigger points was leading to your faulty movement pattern, and the faulty movement patterns was leading to your postural syndrome. So this cycle would continue. So if you want to get relieved by the pain, you have to break somewhere in between. So that's why what I say, for the treatment part, first we should go for a good assessment. What assessment? You should go for the assessment of the faulty movement pattern. And you should be able to find it out what postural syndromes are there and where are the trigger points are there. Then the treatment would be very simple. When you have find it out what are the postural syndromes are there, where are the trigger points are there, you have to go for the lengthening of the shortened muscles through the soft tissue mobilization. And the weak muscles should get strengthened. That's why strengthening of the weak muscles. And you have to correct your posture. You should go for the postural correction. And for the prevention of further diseases, you should go for your home exercise program. I'm not against the manipulation or your osteopathic technique. I am a trained manual therapist is there. But what I find it out, if you go for high velocity thrust or the manipulation for the hypomobile joint, it's good. But the relief is for the few days. Again, the muscles would go in the tightening position, and again, because the weak muscles are not in the habit of work. So again, this postural syndrome would be there, and your client would come again with the pain. So if you want the 100% relief, you should prefer your soft tissue mobilization for the lengthening of the shortened muscles. And definitely you have to go for the strengthening of the weak muscles, because there is not a short way. There is not a shortcut for getting relief. It can relieve for a few days, but if you want a long-term management, then you have to treat all these faulty movement pattern and the postural syndrome. So there is lot of techniques has been developed by the physiotherapist for the soft tissue mobilization. Few are your muscle energy technique, serious concept of deep transfer friction massage, trigger point therapy, ischemic compression therapy, and the myofascial release. Today, I would like to discuss few one with you. First is the muscle energy technique is there. Muscle energy technique are a class of soft tissue osteopathic manipulation methods that incorporate precisely directed and controlled, patient-initiated isometric and or isotonic contraction designed to improve musculoskeletal function and reduce pain is there. You would say, sir, you are using the muscle energy technique. Okay, if there is a shortened muscle is there, why we shouldn't go for the stretching of the muscle? But my dear colleagues, when we go for the stretching of this thing, first thing that we stretch, it is the skin. Second thing we stretch is the fascia. Our force up to your muscle is very limited. What the Janda and Levitt find it out, if you have to lengthen the muscles, use the muscles' own energy by using up the isometric or the isotonic contraction and then release the muscle. And with this simple technique, muscle energy technique, it can be used with precision to release and realign your spinal joints from the atlas to your sacroiliac joint. With this simple technique, you can release and realign all your spinal joints from the atlas to your sacroiliac. So there are the two techniques are there for the acute condition and for the chronic condition. If there is an acute part is there, then we use the isometric relaxation, post-isometric relaxation. PIR technique, it is famous by the name of the PIR. It was described by Levitt, is a method of reducing or relaxing muscle tone in acute situation in muscles that demonstrate muscle hypertonicity and with muscles containing trigger point. So, dear colleagues, we are using PIR for the acute cases are there. For this thing, how we use the PIR technique is there is a barrier concept is there. Normally we find it out the two barriers are there. One is your physiological barrier. You can see this is the physiological barrier for my elbow extension. Beyond this, there is an anatomical barrier is there. And in between this, there is an active range of motion is possible. If there is any pathology, if there is any restriction, trigger points or any faulty movement pattern is there, there would be a restrictive barrier would be there. So what the Levitt says, you have to find the restrictive barrier. In the diagram, you could see for the, I'm doing the MET for the your trapezius to just find it out your barrier point. At the barrier point, use the muscle energy. How much energy? You have to go for the 20% of the isometric contraction of the muscle power. And after that, what would happen? There would be reciprocal relaxation would be there. And there would be the lengthening of the muscle. So this technique you can use in the acute case. So, but the basic principle for the PIR is the patient positioning. It is important what the position of maximal comfort and lengthening is there. And you should be able to find it out the barrier. Where is the barrier? Engaging barrier is the main concept. Then you would be using the isometric contraction. Along with this, you want to use up the autonomic nervous system to use the breathing pattern also. When you would be relaxing, there should be the exhalation should be there. And see your client to see towards the movement. Its eye movement should be there. So there would be you would be using the breathing pattern, you would be using the eye, and there would be, along with this, you can use the tap. And you would be saying contract, contract, contract. So there would be the auditory also. So with this thing, you would find the more relaxation of muscle would be there. And you would feel the release and the lengthening of the muscle is there. Then the gender find it out. There are sometimes a lot of trigger points are there which are chronic in nature. At that time, PIR doesn't give relief. Then he developed the technique in which he said we should use more contraction. How much? In the PIR, we was using 20%. In the PFS, he said we should use the 40%. Along with the 40%, he said we should give the passive stretch also for the fascia. That's why this technique has been named as the post-facilitation stretch. So this was described by gender to lengthen chronically shortened muscle is called post-facilitation stretch technique, much more vigorous approach than the PIR technique. Tight muscles requiring not only a relaxation of muscle spindle, but also a lengthening of the fascial structure. This technique requires more than relaxation. It also requires an actual stretching of muscle and connective tissue rather than simply taking the muscle to a new barrier is there. So PIR was for acute and PFS is for your chronic is there. My few colleagues says, sir, what is the difference between the hold and relax of the PNF technique and the MET is there? In the hold and relax, we was using the 100% contraction. What we find it out when we use the 20% of the contraction, our slow twitch fibers get activated. And whenever there is a studies is there, whenever there is a shortening of the muscle is there, it is because of the type 1 fibers, slow twitch fibers is there, and they get activated by the muscle energy technique is there. In the PFS also, patient position at the start of contraction, you have to take care, and force of isometric contraction, and then go for the length of the stretch. The main difference between PIR and PFS is the PIR 20% stretch, PFS 40%. In PFS, you are also using your passive stretching. So you have to instruct your patient to provide minimal contraction when instructed to 20%. Sometimes your client will try to go for the more and more contraction. Just teach them, okay, this is your 100%. You have to use 1/5 of that time. So first one class would be just teaching about the 20% and 40%. Make every attempt to avoid pain or discomfort when you are applying a PIR technique. When there is a PFS technique for the chronic cases, do not stretch too aggressively. Instead, take muscle only up to the barrier and apply a gentle stretch beyond that point. And when possible, have the patient assist in the stretch by contracting the antagonist muscle is there. The side effect of MAT, I couldn't find it out. It is a very safe technique. You can do easily. With the PIR, post-treatment soreness and stiffness can occur, especially with the inexperienced persons. With PFS, the patient often feels post-treatment soreness, but this soreness should dissipate within the minutes to the hours. When sometimes these hours could be the 24 hours, when your client would be coming for the next sitting, his or her pain would be gone. Contraindication, if there is a suspected pathology, you are not confirmed about the diagnosis, don't go for MAT. If there is a hypermobility or instability is there, don't go. Fracture, tumor, infection, or the others, if the patient is not able to take your command, then don't use a muscle energy technique. And the second technique was given by the Syriacs for lengthening up this fibrous tissue is there. What he says when there is a fibrosis is there, what happens in the muscle strain? In the muscle strain, a few fibers to the part resulting in a scar tissue that matched the fibers together not only longitudinally but transversely also. And these microscopic adhesions cause pain when the muscle broadened or contraction. And these painful adhesions can be broken by the deep massage. So what happens up? There is a transverse adhesions are there. Okay, so you have to break these adhesions by the deep transverse friction massage. So massage should be in the transverse pattern. If I am giving on for the transverse ligament is there, so it should be transverse. So direction should be transverse. Again, for application of the deep transverse friction massage, you should find the precise site because you have to dissolve the nodule. And you would be using up either the digit, either the thumb, and sometimes we use the whole 3 to 4 fingers. So digit is rubbed across the structure undergoing treatment. Frictional element, not the pressure element, is the paramount. And the position patient to the render lesion should be accessible and put tissue under treatment into the appropriate tension. The tissue should be in your appropriate tension should be there. Usually we use 6 to 10 sessions are required for 20 minutes each on alternate day. Why this goes for what the physiology behind this is there? Deep transverse friction massage mainly work on the 3 effects. First is the traumatic hyperemia. Increase in the temperature is there, which helps into evacuating up your metabolites. Second is it destroys the adhesions. And third is it goes for stimulation of mechanoreceptors. It is a very good technique for reducing up the muscle or the tendon shortening is there if there is any adhesions are there. And as I said, a lot of soft tissue mobilization and manipulation techniques are there, but today I discussed only the mainly muscle energy technique and the deep transfer friction massage. Now the second thing, you have treated the shortened muscles, but what about the weak muscles? So you should work for your strengthening of the muscles. So I'm just giving the few brief exercises, just like bridging, SLR, then the dead bugs exercises, lower trunk rotations, scissors exercises, quadripod positions, crossed arm crunches, then you can go for the lunges, then the dead bug exercises with the use of your Swiss ball. You can use the Swiss ball and you can go for the Y, T and the W exercise with the dumbbells. This is the progression of the exercises are there. You would be going for the progression. Mainly these exercises I have told for the strengthening of the core for the lower cross syndrome, but definitely there are a lot of exercise are there for the upper cross syndrome, for the strengthening of the deep neck flexors, for your retractors, for the serratus anterior and all these things. In the end, I would like to say there are the two way of these things could be there. Just do nothing. And on the another wall, it is impossible. But we would like to unite. And we would say, just do it, because nothing is impossible. And if we all physios get united, definitely we can do. And I would say we all the physios of the South Asian countries, Bangladesh, Nepal, Sri Lanka, we all should come together for sharing knowledge and for sharing skills. Definitely we can uplift our profession. And in the end, if you believe in yourself, you can be whatever you want to be. So never be shy in asking questions and be confident in front of your client. Definitely we physiotherapists can treat all the postural disorders or the things. So have confidence in you and definitely we can become a good physiotherapist. So with this thing, I would like to end my lecture. This is my email address is there. It is very easy to remember. My dear friend says, why you have kept it like this? After doctorate, you are writing shagunbpt@yahoo.com. So I used to say him, I had made this email address during my bachelor's timing. That's why I used up this email address, because it's close to my heart. And my WhatsApp number is +919910259583. If any questions are there, you are open. You can WhatsApp me, you can mail me. Definitely, if the things would be in my hand, I would be sharing with you. Thank you.
Thank you, sir. I think it's a wonderful presentation, and I think in the future we can do hands-on, because everything in case of physiotherapy, there is not only the online base, it's true base, because we are not treating the patient six feet distance, so we need to touch the patient. So
Yes.
everything what we learn, that should be in practical, because without practical we can't remember it for a long time. And I learned from a lot of faculties or lot of teachers, that is, when you listen, then you can learn for 30 minutes, you can memorize for 30 minutes. When you can see, then you can memorize it for 1 hour. And when you teach others, then you can remember it for lifelong. So Sir is the boss in this field, and I think it's the collaboration begins, and I think we can go further, because Sir is giving us on a soft tissue mobilization. Maybe next time we will go for manual therapy and any other special technique, because he has got a lot of techniques from certificate program from abroad, not only in India.
Definitely. It's a learning process for all of us. During this COVID times, we have learned how to go on the Zoom, how to go for the StreamYard, how to use up the Google Meet. And definitely next time, I would like to just show the a few videos onto the live patient. So if we can keep it in the afternoon timings in my college time, then I can use the model and I can demonstrate the few techniques to our all the audience. So next time I would prefer we can do, if it is possible, we can do in the afternoon when I have got the client with us, and definitely I would like to demonstrate the all the techniques of the MET, CREX concept and all these techniques.
Yes, that's true, sir. Because after completing of BPT, some students are maybe they feel like us, like which technique they will apply on patient, or which one is based and which one is not now, which one is later. So they may have confusion about that. So when you like senior person and senior sir will discuss it very clearly, then it will be helpful for their future practice.
Dr. Shantanu, I would say like this. Nowadays, in our Bengal, we celebrate the Durga Puja. So,
Yes,
Dr. Ma Durga is having the 8 hands, and she
same
is
answer.
having the,
Same
in one
answer.
hand, she is having sword, in the another hand, she is the another instrument. So, in her hand, you have got the lot of instrument. Okay, same with physios. We
Yes,
should have all the techniques with us. So, Ma Durga teaches us that we should learn all the techniques, but we should know when to use which technique. That is more important, is there. When we should use the arrow, when we should use the sword, and that the thing is there. If you are able to know ki, okay, at this time I should use the soft tissue mobilization, at this time I should use the high velocity thrust, I should use taping, I should use dry needling, and the different techniques are there in physiotherapy. So that depends upon to the your, with your experience, you would come to know which technique is good for my client is there. So I would say we should learn all the techniques, we shouldn't leave a single one, and but we should know which technique would be good for which client.
that's true, sir. That's true, sir. Sir, already I would like to inform our participant that is we have shared our feedback link. So by fill up your our feedback link, you can directly access the certificate for today webinar. So I am requesting our patient, that is participants, uh, if they are asking any question. So I am looking for some question, whether they are asking or not. So okay, question. A lot of people are giving thanks, and especially they are giving thanks. It was very informative and useful session. And then question, not not very.
I think lecture was not interesting. That's why there is no
No,
question.
no, 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 no. Not
My
no,
teacher used to say, if there is no question, sometimes either the topic is so boring or either you are able to explain it everything. But nobody is in this world is who is 100% correct. So
So
I'm
there is
making it
only,
like
yes.
this.
So Khalik Ahmed, he's asking about whether we inspire during contraction or relaxation in MATE, muscle energy technique.
When you are going for the relaxation, then you have to exhale. During the relaxation, after the contraction, when you are relaxing the muscle, then you have to go for exhaling. Along with the relaxation, exhale.
Okay. So I think there is no more question yet. But sir, I can ask you question, sir, because like before that we are used to know that muscle is our bread and butter. But nowadays we have come to learn that the fascia is another important part for physio nowadays.
Yes.
So it's not a muscle release; it's now myofascial release. So
Yes.
uh, how it is important, like this is the superficial structure or deep structure, but we are always looking to correct the bones. But without correct the soft tissue, we'll not get the 100% result. So
Yeah,
can you
this is
explain
the
this?
Shantanu. Yeah. This is the thing is there because nowadays what I am finding it out, we are more focusing on the manipulations and all these things, spine manipulation or the parallel manipulation. But the thing is, the first layer of protection is first is skin, then the superficial fascia, then the deep fascia, and then comes the muscle. And all the dysfunctions are coming because of the tightness. If there is a muscle tightness is there, that's why when I said in the chronic cases, you would find it out, there is a fascia would be tight. That's why I used up the PFS technique, post facilitation stretch, in which along with the muscles I was releasing the your fascia also. That's why whenever there is a chronic cases are there, we should release the fascia also, because fascia is the integral part and fascia is everywhere.
Yes, sir, that's true, sir.
So that's
And
why this is a myofascial model is there, and it is just like a trajectory. If you are stretching up it here, it would stretch into your lower limb also. Okay, so you should be, there is a different chain system is there, that is the anatomy trains are there, so you have to release all these chains.
that's true, sir. Okay, sir. So I think we can. How long we have taken, sir? It's that's 18. Sir, do you like to share any
Okay.
videos?
No, no. I would take it in the another class when I would take in the afternoon. Okay. If there
Okay.
would be any question, they can WhatsApp me and they can mail me. Definitely, I would like to give answers. Okay. And definitely, we would work together. We both countries are neighboring countries, and we would work together. Okay.
Okay. Okay.
Okay.
So,
Okay.
so
Shubhoratri.
we can,
Shubhoratri.
yes, sir.
Yeah.
Yes, sure. Yes. Thank you, sir. Namaste. So, thank you, everybody. And I think it's a very good and nice and informative session. It's a little bit short, but we can plan for next time. It's a very long time and also hands-on approaches. So, another announcement is next Sunday we'll be to arrange a mobilization approaches with another faculties. He is from India, and that will be on number spine assessment. So we will very soon we'll share the flyer and also the details of that session on next Sunday. So that will be a little bit earlier, and that start 5:30 in Bangladesh and 6 p.m. in India, and that is start that is 6 p.m. in India. Means, we are 6:30 in Bangladesh and 5:30 in Pakistan. So thank you all, and thank you everybody for having a question. I think we can get the feedback link very soon. And already we have given previous SMS or previous comments. So just scroll it up and then you can see. Okay. So goodbye for today.